Good evening. Welcome to the Anatomy of the Pelvis webinar session this evening. I'm Dr. Venkat Kotam Raju. You can see one of the specialist registrars in emergency medicine up in Nottingham. To start off this evening, I would like to cover the following high-yield topics. So we'll talk about the bony pelvis and the supporting ligaments. We'll also talk a bit about the pelvic floor and its clinical importance. We'll look in detail into a few of the female genital organs. We'll talk about the prostate, and we'll also talk about the urethra, rectum, and the anal canal. Okay, as you can see, the two symmetrical hip bones, the right and the left, which are also known as the innominate bones or the pelvic bones, they're part of the pelvic girdle. And that is the bony structure which attaches the axial skeleton to the lower limbs. If you look at the hip bone itself, it's got three articulations. So one is with the sacrum, forming the sacroiliac joint on either side. The other is the pubic symphysis, which articulates with the corresponding hip bone. And the third one is the hip joint itself, which the pelvis or the hip bone articulates with the neck of femur. This is just another view just to show you the different structures. So that's the iliac crest, anterior superior iliac spine, anterior inferior iliac spine, and that's the acetabulum, which is articulating with the head of femur. That's the ilium. Of course, you've got the superior and inferior pubic ramus, and that's part of the ischium. Okay, what are the functions of the pelvis? The pelvis has three important functions. One is transfer of weight from the axial to the appendicular skeleton. Transfer of weight from the axial to the appendicular skeleton. Provides attachment to muscles and ligaments, and contains and protects abdominal viscera. Okay, so three important functions. It helps to transfer weight from the axial to the appendicular skeleton. It provides attachment to muscles and ligaments, and it contains and protects the abdominopelvic viscera. So that's showing you just the pelvis and the various ligaments. So the important ligaments, of course, are two ligaments are attached to the ischium. So one is the sacrospinous ligament, which runs from the ischial spine, and it attaches to the sacrum. And thereby it creates the greater sciatic foramen, through which vasculature to the lower limb, that is including the sciatic nerve and important muscle piriformis, passes through it. So essentially the sacrospinous ligament attaches from the ischial tuberosity to the sacrum, from the ischial spine to the sacrum, and converts the greater sciatic foramen or creates the greater sciatic foramen, I must say, through which the piriformis and the neurovascular structures pass. The sacrotuberous ligament runs from the ischial tuberosity to the sacrum, and that contributes, or that converts actually, giving rise to the lesser sciatic foramen or forming the lesser sciatic foramen. So sacrospinous and sacrotuberous, two important ligaments which help in the formation of the greater sciatic foramen and the lesser sciatic foramen. Piriformis muscle passes through the greater sciatic foramen as well as important neurovascular structures, including the sciatic nerves. That's just another view, just to show the different ligaments. So that's the sacrospinous ligament. That's the sacrotuberous ligament. This is the iliolumbar ligament, so which is attached to the iliac crest and to the lumbar vertebra. And this bit is the posterior sacral ligament. And as you can see here, This is the greater sciatic foramen, and that is the lesser sciatic foramen. And of course, these two are the obturator foramen. This is just another clear view of the greater and the lesser sciatic foramen, and you can see the sacrospinous ligament here, and you can see the sacrotuberous ligament. So the sacrospinous ligament helps in the formation of the greater sciatic foramen. The sacrotuberous ligament helps in the formation of the lesser sciatic foramen. And both of these ligaments are important attachments to the ischium. Okay? And now you can essentially, that is the greater sciatic foramen, that's the lesser sciatic foramen. Piriformis muscle passes through the greater, obturator internus through the lesser sciatic foramen. And you can talk about structures passing above the piriformis, below the piriformis, which is probably beyond the scope of this lecture. Superior portion of the pelvis is known as the greater or the false pelvis. So this bit, the green bit, greater or the false pelvis. And it just provides support for lower abdominal viscera. The inferior portion of the pelvis is known as the lesser or the true pelvis, in which actually you will find the pelvic cavity and the pelvic viscera reside. And the junction between the greater and the lesser pelvis is the pelvic inlet. The junction is the pelvic inlet, and the outer borders of this pelvic inlet are nothing but the pelvic brim. So greater pelvis, lesser pelvis, pelvic brim, and of course the borders or outer bony edges of pelvic inlet are nothing but the pelvic brim. So if you see here the differences between the male and the female pelvis, as you can see, android pelvis is the male type of pelvis, coid pelvis is the female type of pelvis. Here the pelvis is wider and broader. The ischial spines are less prominent, whereas here the ischial spines are more prominent, and of course the sacrum is sort of longer, and the sacral promontory is more pronounced. And of course, as you know, the gynecoid pelvis has a wider subpubic angle compared to the android pelvis, that is to assist during childbirth. So what the distinct features of gynecoid pelvis are, although it is wider and broader, it is lighter in weight. It has got an oval-shaped inlet compared to this inlet, which is more sort of heart-shaped, sort of android pelvis. The ischial spines are less prominent. So thereby, you know, in obstetrics, you talk about the conjugate diagonals and other things, and that is importance for sort of obstetric practice. Whereas in android pelvis, they are more prominent. Greater subpubic angle, which we've already talked, and I've said sacrum in the android pelvis is more pronounced, it is longer, and the sacral promontory is more pronounced in the male, whereas in the gynecoid pelvis, the sacrum is shorter, it's more curved, and it's got a lesser pronounced sacral promontory. So essentially, wide subpubic angle, less prominent ischial spines, wider and broader sort of inlet, and less pronounced sacral promontory and shorter sacrum. All these features help to provide more room in the pelvis. Okay, so that's a little bit of introduction about the hip bones, the articulations of the hip bones and parts of the pelvic girdle, important ligaments, the greater and lesser sciatic foramen, and of course we've looked at the male and the female pelvis and their differences. Before we move on, one last thing I want to mention is, of course, as you know, the pelvis as a whole, or the pelvic bones, they are very prone to injury during trauma. And of course, there are two common ways that you can injure your pelvis. One is you have a direct trauma to the pelvic bones from a road traffic accident, or sometimes when you have a heavy fall on your feet, if you're falling from a height, if you're landing on your feet, then you can have forces which are transmitted from the lower limbs. And then these forces, of course, they are transmitted right up into the pelvis. And you can have fractures which usually occur at the weaker points of the bones. And these weaker points are the pubic rami, they are the acetabulum, and they are the region of the sacroiliac joint. So three weak points: sacroiliac joints, rami, superior and inferior pubic rami, and as well as the acetabulum. So direct trauma or indirect with forces transmitted from up the lower leg when you land heavily. I want to move on to pelvic floor now. So if you look at the pelvic floor is a funnel-shaped muscular structure. And what does it do? It attaches to the walls of the lesser pelvis. Remember, I told you lesser pelvis is the one which is important. Greater pelvis has got no obstetric relevance. Thereby, by attaching to the walls of the lesser pelvis, it separates the pelvic cavity from the inferior perineum. Inferior perineum is nothing but the area which includes the genitals and the anus. And we look at the pelvic floor and the muscles in detail, but the structures, of course, as I said, in order to allow for urination and defecation, there are few gaps, and these gaps contribute to the urogenital and the rectal hiatus. It will become more clear when I talk about it in the next slide. And what are the functions of the pelvic floor? Essentially, the pelvic floor, they support the abdominopelvic viscera. They have resistance to increases in intrapelvic or abdominal pressure. So they resist any increases in intrapelvic and abdominal pressure, and also they play a very important role in urinary and fecal continence, not incontinence. A dysfunction of the pelvic floor will result in urinary and fecal incontinence, whereas an intact pelvic floor will help to maintain urinary and fecal continence. And of course, levator ani is the important muscle which contributes to the pelvic floor. So as I said, in order to allow for urination and defecation, there are few gaps in the pelvic floor, and these two gaps are, one is the urogenital hiatus. This is the anteriorly situated opening, this part, and this allows passage of the urethra, and in females it also allows the passage of the vagina. Posteriorly situated, or rather more central, I would say, rather than more posteriorly, because this is the anterior pubic symphysis coccyx and is more central rather than actually true posterior. You have another opening called the rectal hiatus, which provides or passage to the anal canal. And between these two, of course, you can't see in this projection, you have what is called, between the urogenital hiatus and the anal canal, there's a little fibrous node which is known as the perineal body. And this perineal body joins the pelvic floor to the perineum. Okay. So muscles of the pelvic floor. I said pelvic floor is a funnel-shaped structure, and there are three components to it. So levator ani, coccygeus muscle, and of course the fascia covering these muscles. So levator ani, we'll discuss about that in detail. The coccygeus muscle, which is this bit here, that's the levator ani, and also the fascia covering. These contribute to the pelvic floor. We'll talk about the levator ani in a bit more detail. So levator ani is a broad sheet of muscle. It is composed of three paired muscles. That is the pubococcygeus, puborectalis, and iliococcygeus. Levator ani is an important component of the pelvic floor, and it's got three components: pubococcygeus, puborectalis, and iliococcygeus. Coccygeus is a part of the pelvic floor, but not part of the levator ani. It is more posteriorly situated. Puborectalis is a U-shaped sling, as you can see here. The puborectalis muscle is a U-shaped sling, and it extends from the bodies of the pubic bones past the urogenital hiatus around the anal canal. And the tonic contraction of this puborectalis muscle creates the anorectal angle at the anorectal junction. And the main function of this puborectalis muscle is to maintain fecal continence. So during defecation, this muscle relaxes. So it's a U-shaped sling. It has tonic contraction and contributes to the formation of the anorectal angle at the anorectal junction. And main function of this muscle is to maintain fecal continence. On the other hand, pubococcygeus muscle, the muscle fibers of pubococcygeus are the main constituents of levator ani. And some of these fibers in the male, they sort of divide and loop around the prostate in the male, and in the female, they loop around the vagina. Ileococcygeus, on the other hand, the muscle fibers are very thin, and posteriorly they attach, as you can see, they attach to the coccyx and also to the anococcygeal ligament. So three muscles, out of which puborectalis you need to remember, because it plays a role in fecal continence. Coccygeus muscle, on the other hand, as I said, it does not contribute directly to the levator ani, but it is a part of the pelvic floor. It's a small muscle, most posterior muscle of the pelvic floor component. Levator ani muscles are situated anteriorly, and this coccygeus muscle, it originates from the ischial spines and it travels to the sacrum and the coccyx along with the sacrospinous ligament. So we've talked a bit about the pelvic floor. One last thing to mention before we go on to the female genital organs is coccygeus muscle is innervated by the anterior rami of S4 and S5, not by the pudendal nerves. So very important, sometimes that question can be asked as well. Coccygeus is innervated by the pudendal nerve. No. Levator ani muscle and its components are innervated by branches of the pudendal nerve, whereas coccygeus muscle is innervated by anterior rami of S4 and S5. What is the clinical relevance? I said we've already talked about it. So in pelvic floor dysfunction, so the pelvic floor acts to support the pelvic viscera. If the muscles become damaged, then of course you can have this dysfunction of these viscera. And these levator ani muscles, they help in supporting the fetal head during cervical dilatation. That means when during childbirth, when the cervix begins to dilate, they help to support the fetal head. And as I've already said, the puborectalis and pubococcygeus, because they're situated more medially, more likely to be damaged, as is the pudendal nerve. And thereby, they can lead to urinary stress incontinence as well as rectal incontinence if the damage occurs. And especially, these urinary and rectal incontinence is more noticeable during activities which increase the intra-abdominal pressure, like coughing or sneezing or lifting heavy weights, so on and so forth. Okay. Let's move on to the uterus. Okay, as you know, the uterus is a secondary sex organ. Secondary sex organs are components of the reproductive tract that mature during puberty under the influence of sex hormones produced from primary sex organs. So the primary sex organs are the ovaries in the females and the testes in the males. And whatever sex hormones these produce, the secondary sex organ like the uterus matures. And as you know, it's got three parts: fundus, body, and cervix. Fundus is top of the uterus, above the entry point of the uterine tubes. Body is the usual site where there is implantation of the blastocyst. And cervix, of course, is the lower part of the uterus which links it to the vagina. Anatomical position is anteverted and anteflex. You can have various combinations of it. Ligaments. Let's look about the ligaments in detail. So essentially, the tone of the pelvic floor provides the primary support for the uterus. The tone of the pelvic floor. And of course, some ligaments provide further support which secure the uterus in place. Let me get a better picture. So ligaments of the uterus can be classified or broadly sort of divided into a broad ligament, round ligament, ovarian ligament, cardinal ligament, and uterosacral ligament. Broad ligament, so if you look here, we've removed the broad ligament from the right side, but that is number 4. So essentially, it's a double layer of peritoneum which attaches sides of the uterus to the pelvis. And it acts as a mesentery for the uterus and contributes to maintain the position of the uterus in the pelvis. That's the broad ligament. Round ligament, which is number 3, that bit here, and that is nothing but a remnant of the gubernaculum, which extends from the uterine horn. So these are the uterine horns to the labia majora via the inguinal canal. So 2 things to remember about the round ligament. 1 is the remnant of the gubernaculum. 2, it functions to maintain the anteverted position of the uterus. It functions to maintain the anteverted position of the uterus. So if a question is asked, which ligament contributes to the anteverted position of the uterus? It's the round ligament of the uterus. Ovarian ligament, as the name suggests, joins the ovaries to the uterus. And the cardinal ligaments, because you can't see all in one picture. Let's see if we can I'll show you another picture where you can see the cardinal ligaments. They are located at the base of the broad ligament. They extend from the cervix to the lateral pelvic wall. And what they do is they contain the uterine artery and vein in addition to providing support to the uterus. So important things to remember about uterine ligaments. Broad ligament is a double fold of peritoneum. Round ligament is a remnant of the gubernaculum and maintains the anteverted position. Cardinal ligament contains the uterine artery and vein. Okay. So if you look at it in more detail, anatomically, the broad ligament can be divided into 3 things: mesometrium, mesosalpinx, and mesovarium. So if you look at it, that's the uterine tube, that's the ovary there, and of course it shows the 2 layers of the broad ligament which are splitting the anterior layer. Mesometrium, which is the yellow part here, mesometrium surrounds the uterus and it is the largest subsection of the broad ligament. It runs laterally to cover the external iliac vessels. So mesometrium is the largest subsection and it runs laterally to cover the external iliac vessels. Mesovarium, as you can imagine, it's part of the broad ligament that is associated with the ovary. That bit. Part of the broad ligament which is associated with the ovary. So that bit, mesovarium. And it projects from the posterior surface. As you can see, this is the anterior part. This is the posterior part. Projects from the posterior surface, encloses, sort of attaches to the hilum of the ovary, enclosing the neurovascular supply. Closing the neurovascular supply. So important. Hilum means where structures enter and leave an organ. Hilum of the lung, hilum of the ovary, whatever may be the hilum. Structures means mainly the neurovascular structures. So mesovarium, remember, hilum of the ovary and the neurovascular structures run there. Mesosalpinx, as the name suggests, the green bit here, it's part of the broad ligament which encloses the fallopian tubes. 3 other ligaments of the ovarian or of the female reproductive tract are located within the broad ligament. That is ovarian ligament, round ligament of the uterus, and suspensory ligament of the ovary. So suspensory ligament also is part of the, or located within the broad ligament. We'll talk about the ovarian ligaments in a bit, and also we'll talk about the suspensory ligament of the ovary in the ovarian chapter. So in terms of the function, main function of the uterine tubes is to assist in the transfer and transport of the ovum from the ovary to the uterus. What are the parts? It's got 4 parts. One is the fimbriae, which are finger-like ciliated projections which capture the ovum from the surface of the ovary. Then you have the infundibulum, which is a funnel-shaped opening near the ovary to which these fimbriae are attached. Of course, you've got next the ampulla, which is the widest section of the uterine tube, and fertilization usually occurs here. And then you have isthmus, isthmus means neck, isn't it? Narrow section of the uterine tubes which connects the ampulla to the uterine cavity. Ampulla to the uterine cavity. So 4 parts: fimbriae, infundibulum, ampulla, and isthmus. Okay. In terms of talking about ligaments of the ovary. Now we talk about the let's talk a little bit about the blood supply and then we'll move on. Of course, the arterial supply to the fallopian tubes is via the uterine and the ovarian arteries. Venous drainage is uterine and ovarian veins. And lymphatic drainage is via the sacral nodes, iliac nodes, and the aortic lymph nodes. The nerve supply, the uterine tubes receive both parasympathetic and sympathetic innervation via nerve fibers from the ovarian and the uterine plexus. And these sensory fibers run from T11 to L1. What is the clinical importance? Of course, fallopian tubes, you can have ectopic pregnancy, and that can present as an acute abdomen. You can also have infection in the fallopian tubes and leading to salpingitis, which again contributes to ectopic pregnancy. And of course, the other importance is in tubal ligation. So 3 things really. So inflammatory disease, salpingitis, ectopic pregnancy, and tubal ligation. Okay. Let's move on to ovaries. The female gonads are called the ovaries. And as we've already said, the ovaries are paired oval organs which are attached to the posterior surface of the broad ligament of the uterus by mesovarium. Mesosalpinx attaches the fallopian tube. Mesovarium attaches the posterior surface of the broad ligament of the uterus to the ovaries. And neurovascular structures, as we've already said, enter the hilum of the ovary via the mesovarium. And what are the main functions of the ovaries? The ovaries they produce oocytes, which are nothing but the female gametes, in preparation for fertilization. And they also produce the sex steroid hormones, estrogen and progesterone, in response to your pituitary gonadotropins. Okay, so that's the broad ligament, that's the ovary. And I said there are 2 ligaments or 2 peritoneal ligaments which attach to the ovary. One is the ligament of the ovary and the other is the suspensory ligament of the ovary. Ligament of the ovary extends from the ovary to the fundus of the uterus. And then it continues from the uterus to the connective tissue of the labium major as the round ligament of the uterus. Don't get confused. The ovary extends from the ovary to the fundus and continues from the uterus to the connective tissue of the labium majora and then becomes the round ligament of the uterus. Round ligament of the uterus. We've already talked about the round ligament when I spoke to you about ligaments of the uterus. I said it is the remnant of the gubernaculum and it is continuation of the ligament of the ovary and it maintains the anteverted position of the uterus. So 3 things remember about the round ligament of the uterus. Continuation of the ligament of the ovary, remnant of gubernaculum, maintains anteverted position. On the other hand, the ligament of the ovary, it's a fold of peritoneum which extends from the mesovarium to the pelvic wall. And the importance of suspensory ligament of the ovary, as you can see, it contains the neurovascular structures. So two ligaments attached with the ovary: ligament of ovary, suspensory ligament of the ovary. Contains neurovascular structures. Only two things you need to remember. Ligament of the ovary extends from the ovary to the fundus of the uterus, and that part then continues from the uterus, then attaching to the labium majora as the round ligament of the uterus. And three things in the round ligament of the uterus, I've said already: it's remnant of the gubernaculum, it maintains the anteverted position, and of course it is the continuation of the ligament of the ovary. A little bit about the urethra. I'm going to just concentrate mostly on the male urethra. The male urethra is about 15 to 20 centimeters long. In addition to the urine, of course, it provides an exit for semen. And anatomically, it's got four parts. So the yellow bit where you can see is the pre-prostatic part, or it's called the intramural part. It begins at the internal urethral orifice, located at the neck of the bladder, and passes through the walls of the bladder and ends at the prostate. So the pre-prostatic is the intramural, beginning at the internal urethral orifice. The prostatic part, on the other hand, it passes through the prostate gland. And the ejaculatory ducts, which contain the spermatozoa from the testis and the seminal fluid from the seminal vesicle gland, and the prostatic ducts drain into the urethra here. So essentially, all the openings are there in the prostatic urethra of the ejaculatory ducts, and as well as the prostatic ducts and the seminal vesicles. The membranous urethra, which is the little greenish colored bit, that is the structure which passes through the pelvic floor, and it is surrounded by external urethral sphincter, and this is important for providing voluntary control for your micturition. The prostatic urethra passes through the prostate, membranous urethra passes through the pelvic floor and helps to provide voluntary control of micturition. Lastly, the spongy urethra passes through the bulb as well as the corpus spongiosum of the penis, and that ends at the external urethral orifice. And of course, as you know, in the glans penis, this bit dilates, and that forms the navicular fossa. Isn't it? In the glans penis, the part of the dilates, forming the navicular fossa, and the bulbourethral glands, they empty into the proximal urethra. So four parts: pre-prostatic, prostatic, membranous, and spongy. Okay, so as we have said, prostate, four parts: pre-prostatic, prostatic, membranous, and spongy urethra. Now, I mean, this diagram is just essentially show you that, when you catheterize, it's essentially nothing but inserting a tube through the urethra into the bladder. And compared to the females, in the males, it is a more complex thing because you have two angles to consider. One is the infrapubic angle, and of course the prepubic angle. And in the males, if they have got enlargement of the prostate, that makes catheterization even more difficult as well as tricky. This prepubic angle, of course, you can sort of straighten it out by holding the penis upwards during catheterization. Not only the two angles, the prepubic and the infrapubic angle, you've got also natural constrictions in the male urethra. And these constrictions are at three places. One is the internal urethral sphincter, the next is the external urethral sphincter, and the third one is, of course, at the external urethral orifice. So two angles to consider: prepubic and infrapubic angle. Prepubic angle you can straighten out while catheterization, and of course you have to be careful to negotiate in patients who've got enlarged prostate. And you've got typically some of the catheters which are called the Tiemann tip, which are more than the conventional Foley's catheters, and they've got a little tip at the tip as the sort of the end, and that helps to pass through the prostate, making catheterization that much more easier. Okay, I want to talk quickly about the prostate now. We haven't got much time, but if you're okay with it, I'm just going to continue just to give me a few more moments so that we can talk about a couple of other things, and then we'll try to round up if that's okay. So the prostate is about the walnut size. It is a fibromusculo-glandular organ. It's got sort of the glandular component makes up 2/3 of the gland. The fibromuscular is 1/3. It's got a dense capsule, and this capsule incorporates the prostatic plexus of nerves and veins. Now it's got a base, so the parts are the base, and this base is related to the neck of the bladder. It's got an apex, which is related to the urethral sphincter. It's got an anterior surface, which you can't see here, by what we call retropubic space, and this retropubic space is filled with venous plexus. And the posterior surface, as you can imagine, is related to the ampulla of the rectum, and laterally is related to the levator ani. If you talk about the lobes of the prostate, you have got the posterior lobe. So let's look at the posterior lobe, and this posterior lobe lies posterior to the urethra and inferior to the ejaculatory duct, and this is the lobe which you can actually palpate much easier during a digital rectal examination. It's also got lateral lobes. So on this one you can't see lateral, but you can see it here. Two lateral lobes, or they're called the right and the left lobes, and they form the major part of the prostate. And then you've also got a middle lobe, which is also called the median lobe. Middle lobe or the median lobe, and that lies between the urethra and the ejaculatory duct. So that's the ejaculatory duct and the urethra. That lies between the urethra and the ejaculatory ducts. That is the one which can get enlarged, and it can project and cause problems. And of course, it's got an anterior lobe, which is the equivalent of what we used to be called the isthmus of the prostate gland, lies anterior to the urethra. Very important, anterior lobe has got no glands. Anterior lobe has got no glands. It is only muscular, and it is thought to be a continuation of the urethral sphincter. So if they ask you a question, which lobe of the prostate is purely glandular, is anterior lobe. And it's purely muscular, not glandular. It's got no glands. So in which glands are absent is anterior lobe. It's purely muscular, and it is a continuation of the urethral sphincter. Which one can be palpated readily? It's the posterior lobe. Which lies between the ejaculatory ducts and the urethra? That is the middle lobe. Which enlarges? It's the middle lobe. Which forms the majority of or which contributes to the bulk of the prostate? That's the lateral lobe. And people talk about the zones in terms of histology, the transition zone, central zone, and peripheral zone, which you can read about. Okay, the same thing there. It just tells you what I've just told you. In terms of the nerve plexus, they talk about the lumbosacral plexus. It is in your curriculum, so I've just included a quick diagram, and just to give you an overview of the innervation in the pelvis. You've got the lumbosacral trunk, you've got the sciatic and the pudendal nerves, and you've got the pelvic splanchnic nerves. Of course, you've got the sympathetic and the parasympathetic chains. Essentially, the nerves of the pelvis, they are derived from three sources: the lumbosacral plexus, the inferior mesenteric plexus, and the sympathetic chain itself. The lumbosacral plexus is made up of L4 and L5, as well as S1, S2, and S3. L4, L5 merge to form the lumbosacral trunk. L4, L5, S1, S2, S3 form the sciatic nerve, and of course you've got other combinations which contribute to the formation of the superior and the inferior gluteal nerve. S4 is not a part of the lumbosacral plexus, but it joins S2-3, and they form the pudendal nerve, which supplies structures in the perineum. It is of obstetric significance because two things. One is during childbirth, the pudendal nerve can be damaged. Secondly, levator ani has got innervation from branches of the pudendal nerve, and if that is damaged, the pudendal nerve is at risk of being damaged. And of course, to help with the pain, you can give a pudendal nerve block, which you can read about. Inferior mesenteric plexus, it starts out in the abdomen at the point of the inferior mesenteric artery and passes along the aorta to the presacral lesion, and it splits into right and left hypogastric plexus that lies behind the rectum. And sacral sympathetic plexus is nothing but a continuation of the lumbar chain. Whereas the sacral part of the parasympathetic nerve arises again from S2, S3, S4, and besides supplying the pelvic structures, it also supplies the abdomen, like the left coeliac flexure, the descending and the sigmoid colon. Okay. The last part of the talk is we'll quickly run through rectum and anal canal, which will be a quick run through really. The rectum, of course, is the most distal part of the colon. It begins at the level of the S3 vertebra. Proximally, it is continuous with the sigmoid colon, distally with the anal canal. Rectum is the retroperitoneal structure. And distal portion of the rectum, as you know, is expanded to form the rectal ampulla. If you look at the rectum macroscopically, it lacks the characteristic features of the large intestine. How do you identify the large intestine macroscopically? Three things, isn't it? It's got saculations, it's got spine. And as the rectal ampulla narrows at the pelvic floor, it gains the internal and the external anal sphincters and then becomes the anal canal. In the pelvis, of course, as you know, there are extensions of the peritoneal reflections. In the case of men, it is between the posterior part of the bladder. So the bladder and of course the rectum in the men. So rectum and bladder, that forms the rectovesical pouch in the diagram in the right lower corner. So the rectovesical pouch between the posterior wall of the bladder and the colon. And of course in the woman, it is formed between the posterior wall of the uterus and the rectum, which forms the rectouterine pouch, which is also called, or which is commonly known as the pouch of Douglas. And what is the important thing is you can do a procedure called culdocentesis, which is nothing but, because it's sort of the dependent part, any fluid accumulation accumulates in the rectouterine pouch, and when you insert a needle to the posterior fornix of the vagina, you will reach the pouch of Douglas, and you can extract fluid from the peritoneal cavity, or you can drain a pelvic abscess from the rectouterine pouch. That is important. So how do you approach it? From the posterior fornix of the vagina, and you can drain it, or that's called culdocentesis. Okay. Cervix and the rectouterine pouch. In both the sexes, if you go posteriorly, you can feel the sacrum, you can feel the coccyx. If you go laterally, you can feel the ischial spine and the tuberosity. And of course, if there is pathological enlargement of the internal iliac nodes, or there's thickening of the ureters, or if there is a swelling of the ischioanal fossa, you can palpate it through the digital rectal examination. So all were true except the ductus deferens, which you can't palpate. So it's very important because it is specifically mentioned in the syllabus. Structures that palpate during a digital rectal examination. Similarly, please read up on the structures that are palpable or that you can palpate during a pervaginal examination. Because of a lack of time, I have not been able to include it in the whole talk, but it's something to read up. It can come up in the exam. Right. So the last bit, of course, is the anal canal. I've said rectum, of course, most distal part of the colon is the rectum. And this rectum begins at the level of S3, continues proximally as with the sigmoid colon distally with the anal canal. Anal canal is continuous with the ampulla of the rectum. And of course, it is surrounded by internal and external sphincters, which are supported by the levator ani muscles. And it has got anal columns, it has got anal sinuses, and it has got anal valves. So if you look at this diagram, it will show you. So it's got anal. This is all the bits of the anal canal. So it's got anal columns, which are nothing but vertical folds containing veins of rectal plexus, and the sinuses are the pockets between the columns, and the adjacent columns are connected by valves. So their valves are nothing but folds connecting adjacent columns, forming the anal sinuses. And as I said, it's got internal, external sphincters. Internal sphincter is involuntary. It surrounds the superior two-thirds of the anal canal, and it's a thickening of the circular muscle layer, not the external sphincter, but the internal sphincter is a thickening of the circular muscle layer. Normally, the internal sphincter is sort of tonically contracted, and this contraction or tonus is stimulated and maintained by the sympathetic fibers. On the other hand, it is inhibited. The sphincter is inhibited means it loses its tonic contraction and it is allowed to expand passively by the parasympathetic fibers. And most of the time, the internal sphincter is tonically contracted, and that is to prevent leakage of fluid and flatus. But when there is sort of feces or gas in the rectal ampulla, it relaxes temporarily to distension of the rectal ampulla. So presence of feces or gas in the rectal ampulla, the internal sphincter temporarily relaxes. And of course, if defecation is not to occur at that point, you need to have voluntary control of both puborectalis and external sphincter. If the voluntary control of the external sphincter is lost, then obviously it will lead to incontinence. And I said puborectalis maintains it's a U-shaped sling, and it has a role to play in fecal continence. On the other hand, external sphincter is a voluntary sphincter. It's innervated through the inferior rectal nerve, and it's got three parts: superficial, subcutaneous, superficial, and deep. Let me see if you can get the diagram. So three parts, if you look there. So that's the internal sphincter, which is continuation of the circular muscle. You've got the longitudinal muscle there. And the external sphincter has got three parts: so subcutaneous part, superficial part, and deep part. And of course, it blends with the puborectalis. So puborectalis, along with internal sphincter, along with the external sphincter, by their voluntary contractions, play a role in fecal continence. And of course, as I said, the anal canal is a watershed line, and at the level of the dentate line, things change. Arterial supply above the dentate line is superior rectal vessels. Below the dentate line is inferior rectal vessels. Venous drainage above is superior rectal to the portal system, and below is to the caval system. Nerve supply again, it's a watershed essentially. So above the sympathetic, above the dentate line is to the pelvis plexus of nerves, and below is to the pelvic splanchnic nerves. Whereas below the dentate line, the anal canal, the skin is very sensitive. It's supplied by the inferior rectal branches of the pudendal nerve. Lymphatic drainage, very important, usually asks. Above the dentate line, it drains to the internal iliac nodes. Below the dentate line, it is to the superficial inguinal nodes. And of course, the epithelium as well is different because of the developmental structure. And epithelium above the dentate line is mucous membrane, and below it's similar to the skin. So it's stratified squamous epithelium with hair and sebaceous glands. That's why the superior part of the anal canal, it is inferior to the pelvic pain line, whereas the nerve supply inferior to the pectinate line or to the dentate line is sensitive, is very sensitive. Essentially, it is sensitive to pain, it's sensitive to touch, it's sensitive to temperature. And somatic efferent fibers, they stimulate the contraction of the voluntary external anal sphincter. Very important. So above only, it is sensitive to even things like pain, touch, and temperature. And as I said, the vascular supply, arteries and veins, they differ. Above is superior rectal, below is inferior rectal. Venous drainage, above is to the portal venous system, below via the inferior and middle rectal veins to the caval venous system. And the lymphatic supply, as we've talked about, internal iliac lymph nodes above the dentate line, superficial inguinal lymph nodes below. What is the importance? Of course, you've got hemorrhoids there. Internal hemorrhoids are nothing but prolapses the rectal mucosa containing the normally dilated veins of the internal rectal venous plexus. And these are thought to be the result of breakdown of the muscularis mucosa, which is a smooth muscle layer deep to the mucosa. And internal hemorrhoids, which prolapse through the anal canal, they are often compressed by the sphincters, which are contracted, and they impede blood flow. As a result, they tend to strangulate and ulcerate. And you know there is abundant arteriovenous anastomosis, hence bleeding from internal hemorrhoids usually bright red. On the other hand, external hemorrhoids, they have thrombosis in the veins of the external rectal venous plexus, and they are covered by skin. And of course, you know, there are predisposing factors like pregnancy, chronic constipation, anything that impedes venous return, including increases in intra-abdominal pressure. The patients can become prone to these. And as a part of course, in portal hypertension, you know, there's a portal cable anastomosis, which we've talked about between the superior rectal, middle, and inferior rectal veins. They can become varicose, and of course, internal hemorrhoids are due to that. External, of course, you know, they are painful because they are related to and they are covered by skin, and the nerve supply is by the inferior branches or inferior rectal branches of the pudendal nerve. So you have to be very careful. Hemorrhoids are painless unless they have become thrombosed. When they have become thrombosed, because they become external, they become painful. So that's very important. Okay, so remember with the anal canal, remember about the sphincters, and also remember about the watershed line at the level of the dentate line, and importance of the nerve supply and the lymphatic drainage. Okay, so to bring this presentation to a close, so just to recapitulate very quickly, the next few seconds or so, this evening we've talked about some of the high yield topics like the bony pelvis, the various ligamentous attachments to them. We've talked about the importance of the pelvic floor, muscles forming the pelvic floor, and their clinical importance. We've talked about few of the female genital organs. We've talked about uterus and the various ligaments which are related to the uterus. We've also talked about a bit about the fallopian tubes. We've touched on the ligaments which are related to the ovary, as well as the lymphatic and nervous supply to the ovaries. We've talked about the vascular supply of all these organs. We've talked about the prostate and its importance clinically. We've talked about the male urethra, and we've also touched on rectum and anal canal, particularly paying importance to the structures that can be palpated during a digital rectal examination. Please read up about the structures which you can palpate during a normal pervaginal examination. And also, we've talked about the anal canal, particularly paying attention to the sphincters of the anal canal and their importance. And also, we've talked about the watershed, the pectinate line, and the differences in the arterial supply, venous drainage, nervous supply, and also we've talked about the importance of lymphatic drainage above and below the pectinate line, and how the hemorrhoids present, and how they can be painful or painless depending upon the presentation. Hope this session has been useful. Please look into the syllabus and look at what other a few of the topics which we have not been able to cover, and thereby most of it, the important things we have covered in the anatomy of the pelvis. I wish you all the very best for your exam. Thank you very much.